Welcome to today's meeting of the Adult and Communities Overview and Scrutiny Committee. As usual, this meeting is being broadcast live to the public. Those not able to watch live, the webcast will be recorded and made available for viewing on the County Council's website after the meeting. Before we begin, can I please remind everyone to only turn on their microphones when you wish or are invited to speak. I've received apologies from Mr. Durrani and Mr. Morris. We move to item 1 on the agenda, which is the minutes of the meeting held on the 3rd of November 2025. That's on pages 5 to 12. The first item is, as I've the meetings held on the 3rd of November 2025. I move that these are taken as read, confirmed and signed. Is that agreed? I have a proposer. Seconder. Mr. Page. All those in agreement? Lovely, thank you. Next is agenda item 2, question time. I confirm that I've received no questions. Agenda item 3 is questions asked by members under Standing Order 7.3 and 7.5. I can confirm that I've received no questions. Agenda item 4 is to advise any other items which the Chairman has decided to take as urgent elsewhere on the agenda. I have no urgent items. Item 5 is declarations of interest in respect to agenda items. Do any members wish to declare the party whip? No. Item 6, declarations of the party whip in accordance. Oh, sorry.
I wish to declare that I'm a trustee of Melton Mencap.
Item 6, declarations of party whips in accordance with Overview and Scrutiny Procedure Rule 16. Do we have any members who wish to declare the party whip? None. Item 7, presentation of petitions under Standing Order 36. I've not received any petitions. Item 8 is the medium-term financial strategy 2026 to 2027. 2029 to 30 report. This is on pages 13 to 40 of the agenda pack. Can I welcome to the meeting Cabinet Lead members Mr. Abbott and Mr. Crook, the Director of Adults and Communities John Wilson, and Gurpreet Kuna, Strategic Finance Manager, to the meeting for this item. The structure for considering this report is set out on a separate sheet which has been circulated to all members. I will now invite the Director and Cabinet Lead member to briefly introduce the report before we scrutinise the proposals. Thank you.
Thank you, Chair. So as is traditional, we will run through the report in sections as detailed on the paper that members have, and invite questions at the end of each section. So I will just go through the first section. So starting with the service transformation, paragraph 6 through to 10. As you'll note, the development of the budget is in line with the strategy of the department to deliver wellbeing and opportunity in Leicestershire. The strategy was approved by members in 2025, and paragraph 7 details the main elements of that strategy. Just worth also noting that at paragraph 9 and paragraph 10, we do also refer to the regulatory inspections that we've had in the last couple of years that also have a bearing on the budget, particularly the inspections by the National Archive in respect to the Records Office and the Care Quality Commission in respect to adult social care. And as you'll see as we go through the report, some of the growth will relate to those areas. From paragraph 11 we've included a summary of a recent report that was published by the Local Government Association into adult social care use of resources. And we're just providing this as background and context to today's MTFS report. We've highlighted a table there in paragraph 15, which provides a summary of some of the key findings of that report. Overall, the report notes that Leicestershire spends less per head on adult social care than the majority of authorities in the country, and we support roughly the same number of individuals. We also have a higher level of income than most authorities, certainly more than the average authority, to support the delivery of the budget. There will be a full report coming to the March Overview and Scrutiny Committee on the use of resources report. So if members are interested in the detail, we will be bringing a much fuller report to the March Committee. Moving on to the proposed revenue budget for 26-27. You'll see under paragraph 16, there is a table which shows how the budget builds up over the MTFS period. So we start with a net budget in 26-27 of £255 million, rising to £266 million by 29-30. It's worth just noting, as it notes in paragraph 17, that those figures do not include any inflationary growth. So they include demographic growth and they include savings, proposed savings over the period, but what they don't include is inflation growth due to inflation or price increases. The reason for that is that there is a separate corporate contingency for inflation that's held centrally within the authority and applied to the budget once the budget's been approved. So as an example of that, you'll see under 26-27 column, there is a budget transfer and adjustment of £13 million, which came in after the prior year budget had been approved. That 13 million was the equivalent of the inflation for 26-27, which came in subsequent to the approval of the budget, and the same thing will happen next year and the year after and the year after. Paragraph 18 just notes that the overall gross budget for the department is £412 million. We have contributions and income of 156 million, which leaves us with our £255 million net budget. And the table under paragraph 18 then just outlines where that money is spent, and as you'll see, 87% goes directly into commissioned and contracted services for individuals. As we move through the report, particularly as we get into the conversation about savings and efficiencies, you'll note that savings are denoted as either being an efficiency or a saving, depending on the nature of each individual one. And there's a further denotation, is that even a word? I'm not sure that's even a word, of INC, which denotes income. So when we get to those, we can deal with those individually. So I'll stop there. Thank you, Chair, and invite any questions.
Right, thank you. At this point, I invite further questions or comments from members of the committee, the Cabinet Lead member and officers of the revenue budget proposals. Can I please ask, when you're asking a question, you highlight which paragraphs the question is arising from, please, or appendix?
Thank you, Chairman. Thank you for this report, and I will admit I quite like the report because it was all in little sections, so I could follow that easily through. So I assume, Chairman, we're going from paragraph 6 to 10, or are we going up to 16 now?
We're going 6 to 10 up to paragraph 16 to 22. So
okay, so I'll do 6 to 10 first. Thank you. Service transformation. Can you give us some more details? Because later on in the report, I read that there was a reference to Newton. So do I understand that is part of the transformation? Can you talk me around, are they helping to the delivery of services, or is that in-house or whatever? On paragraph 13, it states higher proportion of older adults. I'll come back to it later, but we know that we have got, well, Google tells me about 204,000 older adults and whatever. And as this is increasing, and that it is a lot of them are self-funding, I know all around us they are. So have we built in a sort of risk element, because as pensioners and people and the cost of living, we could see a lot more not self-funding and coming to us? So have we built in some sort of risk? Hang on. No, that will do on this. Thank you.
Thank you. So yes, the section on service transformation doesn't directly address the work that Newton are doing. That does come further later on in the report. So there is a section on the efficiency savings that we are working with Newton Europe, but that is separate to the strategy that was developed by members last year, which is what's driving our main budget. In terms of the older adult growth,
Rick, sorry, can you come back to that, John? So yes, that's what I said. I saw that. So how does the transformation differ to the Newton, savings? Just get my head around that.
So the service transformation element is to reflect the direction of services that we as a department and as a council have established for the people of Leicestershire over the course of the next 5 years. The work that Newton are doing is part of a corporate efficiency programme to look at where there may be efficiencies on the budget that we might be able to deliver over the medium term, but it's not related directly to the strategy of the authority.
So both of them run alongside rather than impacting. Thank you.
In terms of the older adults demographics, yes, the paragraph there relates to the fact that we have a higher proportion of people over the age of 65 than other areas of the country, which is something we know about. We are building that into our growth projections, and as we go on to the next section, you'll see how that builds in terms of the demographics. In terms of whether or not that therefore means that there are more people who will come to us as an authority rather than being self-funding, Gurpreet might also want to respond to this, but my understanding is that we are still in a phase whereby as people age and as people retire and go into retirement, there is still an increasing number of people with more disposable income than not. And that's due to the rise in occupational pensions, and it's due to the assets that people hold, particularly in terms of housing, obviously, as their main asset. There may well come a time, and I know some economic forecasts are suggesting there will come a time when that will change. But I don't think we're in that position at the moment, but I don't know whether Gurpreet want to.
In terms of the projections that we use, we do monitor within the cohort the proportion of people that are self-funders or essentially full costers. And for the last couple of years, it's been relatively static. So we tend to use that proportion and project forward. Now, it is potentially a risk, but we monitor it every year just to see if it has materially changed.
So just one more comeback on that. So do we have actual numbers on how many, we have on the books on each, sort of older cohorts and whatever, actual numbers that we can relate to the amount of that is being spent?
Yes, we do. Yeah.
Mr. King, you have a question?
Yeah. Yeah. Thanks for the presentation so far. I think it's sort of on a similar vein to Mrs. Page, really. I suppose what I'm concerned about is we're seeing, and actually the graphs. I know it's late. It's after it's paragraph 26 and 27, 28, which actually is useful. And so what we can see very clearly is the average cost per service user. In the last few years, there's been a very sharp increase come the 1st of April every year. Now, doesn't explain that directly in the report, but I assume that's related to the national minimum wage, national living wage increases going up very substantially. I mean, it'd just be quite helpful if things like that were pointed out, and perhaps if there was a breakdown in how much the cost of increase is related to things like national living wage and other costs. Because it's not terribly clear from this what is driving the cost increases. And if you look at this for 2021, the average cost per service user was £500, and now it's nearer to £700 in 5 years. That's a nearly £200 a year cost increase. Now that's, by anyone's money, that's a lot of money increase. Similarly, the number of service users, and I know there's a bit more breakdown in terms of the increase in different demands, but what's not very clear later on is that demand because of absolute increase in service users, or is that demand increase because of the actual cost increases that we're expecting and anticipating? And hearing what John said, there's no inflationary increases put in, but actually I think that's a mistake. I think there should be inflationary increases put in, because inflation's not going to be zero over the next during the MTFS. Now, if the council's not allowing for any inflation, that's another significant reduction and another significant pressure that's going to be put on service delivery to then account for the inflationary pressures. So I'm a little bit concerned about that. And so how are we going to deal with inflationary pressures if we're not accounting for that and not allowing for any inflation in any of the budget forecasting that we're doing? It does seem slightly counterintuitive, if I can put it like that. So I'd just be grateful if you could just explain that. Thank you very much. Thank you.
Yeah, so you're right in that we've got a slight reference to it in paragraph 27 regarding the average cost of service user increases. So the steep rise does relate to the annual fee review that we agree as an organisation that we're going to uplift our rates when we pay providers. I haven't got the historical information here, but it is the rates that we tend to agree as a department and with corporate finance as well. The increases are a blend of the national living wage and also CPI generally in what providers experience. So we tend to look at the market and we tend to look at our current rates, and then we apply an inflationary factor to that, and that generally gets applied and given to providers in April, which accounts for that kind of steep rise that you see. The main takeaways, I guess, from that graph is over the last couple of years, the department's been able to try and keep the average cost relatively flat, as opposed to what we were experiencing in 21 and 22, where even after we had the increases in April, there was a broad increase over the course of the year. With regards to the inflation that we build or don't build in the department, it is an instruction that's given to all departments. Inflation is budgeted for within a corporate contingency. It's not within our department, but it will be part of the wider MTFS. And there is a contingency for living wage and inflation that's built into that page. So you will see a higher allocation allocated towards inflation over the 4 years of the MTFS. That in turn gets agreed with the departments, and part of that contingency gets released to the department.
Yeah, so I'm not really sure Okay, thanks for that. I'm not really sure that's answered my question. So really what I'm saying is I think this report, I think we do need a bit more kind of, well, you're not going to get it now, but I think going forward, we should have a bit more breakdown of what these increases are being generated by, the kind of, breakdown really, a breakout of that. Now, thinking about this adult social care, now we're 21% below average of the spend per adult for across England. Yet for some reason, and obviously we're expecting service user contributions, which is above average for council. So I suppose there's two questions really. One is, what's the scope to increase service user contribution? Is that something that you're looking at? Second thing is that if we are only, I suppose it comes back to this demand question. So basically we're contributing. So basically there's a level at which people have to pay for that. They have to be self-funding, okay? And which is quite a low level. So the question I suppose is, in all the thousands of customers, clients that we're dealing with, I haven't seen any breakdown yet, not in this report, how many we expect to be self-funding, how many we expect to be we're going to have to fund because they meet the criteria, and what the projections forward, or what the trends are in those areas. What we've got is just one lump of that's what we think the trend's going to be, but without telling us what's happening underneath that or what we think is going to happen. Because if I think about it, yes, there is an increase in the number of people who are older and going to meet in some senses and who may need support, but equally a lot of those people have got assets, and those assets have grown in value, and they're certainly well above the criteria that the county council sets for self-funding. So I'm just curious why that number of people we're having to contribute towards their care keeps on rising if we've got an increase. So I think we need a bit more, maybe not at this point, but at some point we do need a bit more breakdown of this, of what's actually going on, because I don't have an understanding from this report of what is actually going on with service service users. Is the growth coming from because we're having to pay more because there's more people coming and from the funding group, or is it because we've got people who are kind of sitting halfway in between? We've got more that have got sort of a foot in each camp, so to speak. We're partly funding them, and is that the issue? I haven't got this information, so I think that's really important, and I think we ought to have that kind of level of detail in this report. It's a bit of a gap, I think, but that's all I wanted to say. Thank you.
We can certainly try and bring a report later in the year that will break down the financial status of people who are receiving social care, if that's helpful. In terms of people's contribution, our charging policy is written in such a way as to require people to pay the maximum that they are allowed to pay under the law. So there's very little scope for any additional income from people who draw on support. So what we do is, as part of our charging policy, is we ask people to contribute everything that they are able to contribute under the current national charging guidance. So in answer to that part of the question, no, there is very little opportunity for increasing the amount of charges that we levy on people, nor we would certainly wouldn't want to go any further than the guidance suggests we should. But certainly happy to bring a report later in the year that will detail the numbers of people that we have that contribute, the numbers of self-funders in the county. There is an increasing number of people who are self-funders who approach the council in the course of a 12-month period when they deplete their funds. So that number is increasing, and that's partly due to the fact that, of course, people are living longer, happily. But therefore, they do get to a point where they might have used all their available disposable income and asset, and then approach us to help fund their care.
Mr. Innes.
Thank you, Chair. I was going to ask very similar questions to Mr. King, but just one extra on the other income or the user contributions. I see there's contributions against heads of service and things like that. Is that an allocation that's done through a percentage, or is it worked out, or is there actually a direct relationship between the user contributions and straight to the heads of service and lead practitioners? Just interested on how that's allocated.
Sorry, I'm not quite sure which paragraph you were referring to.
Sorry, I should have said it's the appendix A in page 33. I see that there's income. There's an income column, and there is income against heads of service, lead practitioners, etc., etc. Every line has an income. I'm just wondering how that's allocated.
That's not service user income, but it is income that is Better Care grant and Better Care funding towards those posts to help with the joint health and social care work that takes place.
So it's income that we get from the NHS to fund those posts.
If I could just clarify, the section we are currently reviewing is sections pages 14 to 33, and those paragraphs associated in there. We have been moving over, asking questions which are in the next section that we're going to review, which is growth, which is pages 17 to 35. So if we can contain them into those sections, please, it just allows us to correctly capture those items. Mr. Innes, have you got an additional question?
It actually does say in the first section that we can refer to Appendix A, page 33, and that's what I did.
I'll let you off, thank you. Mrs. Page?
No, I'm sorry, I was going on to page 19. I'll wait.
Thank you very much. Right, we move on to the next section. Oh, sorry, Mr. King.
If I may, Chair, just wanted to come back to the question of Newton. And now, obviously, County Council's got Newton in to look at savings. As I understand, they are looking at in year as well for the budget as well. But what I'm concerned about, having just listened to what the director said and some of the answers to the questions, what we've heard is there's no scope to increase service user contributions, or very limited scope to do that. We've heard that a lot of the demand is coming from people who are having change of circumstances, and obviously there's nothing we can do about that. If they've been paying for their care and they suddenly haven't got the money, or it's whittled down, then because they've lived longer for all sorts of reasons, there's not much we can do about that. So I'm somewhat concerned that that the County Council, the administration, is proposing to well, obviously originally you were proposing not to increase council tax at all, but now you're proposing to increase it, but not by the maximum. As I understand, there's only a 2.99 increase, and you're foregoing the social care increase, from what I can understand, unless that's going to change. Because I do think if this stays as it is, this is one of the second largest areas of the council's expenditure, and I'm really struggling to see where, yes, round the edges there might be some savings that can be made, but really it all comes down to user demand. And unless you're able to cap user demand, which you can't effectively, not in the big spending areas anyway, I can't see. So I know you've got some very clever people at Newton who are paying a lot of money for, but I'm just concerned about how long that's all going to take. And here we are, and there's a huge budget gap, 23 million in the MTFS, and this is a significant contribution towards that budget gap. So I just like to feedback that I do think, and not that I'm an advocate of increasing council tax, far from it, but I'm just curious if that's the administration's proposal to not increase council tax to the maximum, then it does mean that you've got to find savings from other service areas, and the only savings you can make is to cut services. So I'm just wondering if those cuts to services are going to be part of, we're going to get a look at them at some point, because you're going to have to cut. And this is going to have to be one of the areas, along with children and families, where you're going to have to make some savings, because otherwise you can't bridge the gap. So that's what I wanted to say. So I'm just wondering if anyone from the administration can actually shed any light on that. Thank you.
Mr. Crook.
Yeah, it'd be inappropriate for us to really discuss any council tax increases or such thing at this stage, but I can assure you the whole process will be transparent.
Okay.
Anybody else got questions?
Chair,
Mr.
can
Cook.
I also add that we stick to the agenda and not try and talk politics too much about things that may be happening in the future. Thank you.
Thank you, Mr. Crook. Well noted. Right, moving on to growth, which is pages 17 to 20, and appendix, which is on page 35.
Thank you, Chair. So starting at paragraph 23, we start to detail the growth requirements over the period of the MTFS, noting that this is, as we've already discussed, growth reflecting from demand on services rather than inflation, albeit that the two do have a crossover, and the cost of care is also related to demand. In particular, growth derives from older adults and adults with learning disability, because they are the two areas where we spend the most, and they are the two areas where we have the highest number of people in receipt of services. Total growth requirement is 12.2 million in 2026, rising to 29.7 million by 29/30. Forecasts are regularly reviewed and updated. We look at, in terms of developing those forecasts, we look at the numbers of people that we currently have in receipt of services. We look at the trends over time in terms of the demand for services. We project into the future what that demand might look like, bearing in mind demographic growth and population data, and we use both local and national tools in order to do that. You'll see that paragraph 26 and paragraph 27, we have included the charts which outline growth in terms of service user numbers and the average cost of services over the last 4 or 5 years. There has been a significant growth, particularly between 22 to 23-24. That was driven on the back of the pandemic, and the department saw substantial growth at over 3.5%, which was double what we would normally expect to see. But we have put a number of management controls in place, and we are now looking at growth which is stabilising at more moderate levels. As Gurpreet has already mentioned, cost of care rises substantially in April each year as we apply the fee uplifts and the inflationary uplifts on our contracts. What we expect to see, though, is, as far as possible, a flat line between the 2 Aprils, which means that we are controlling the costs in year. Again, in 22 to 23, we saw some substantial increases in year, which were driving the much higher cost of care, but that does now seem to be stabilised, and the market is now responding to the fees that we are providing. In terms of older people's demand, as I said, that's the largest area of growth. It's £5 million in 26-27, rising to just under 17 million by 29/30. We do, as I said, look at both local and national demographic data in order to project that demand, and it is projected not just in terms of, in this report we outline growth by client category, so older adults, people with learning disabilities, people with mental health needs, people with physical disability, but we also behind that have forecast the growth in terms of different service areas. So we're within each of those categories, we're looking at the numbers of people in residential care, the numbers of people in receipt of home care, the numbers of people with direct payments, numbers of people in supported living, etc., etc. So each of those is built up through those service blocks. And you'll see that, as I said, learning disability demand is the second highest in terms of financial demand, 3.8 million, rising to 12 million. That's not necessarily because there are high numbers of people with learning disability, but it is an area where the cost of care tends to be very high because of the complexity of need that those individuals have. There are smaller increases for in mental health services, so 1.4 million rising to 4.3 million, and in physical disability services, 0.3 million rising to 1.3 million over the same period. Alongside the growth in expenditure, we obviously therefore would assume that if we have higher numbers of people in receipt of services, or if we are providing a higher level of service to individuals, that we will see some additional income. So we net that off. So paragraphs 38 and 39 and 40 are income projections where we are suggesting that if we have that level of growth, we would expect to see additional growth in income. So in terms of service income from people in receipt of services, 0.5 million rising to 3.4 million. And in terms of additional growth from the NHS, so if we are supporting more people with complex needs, we would expect there to be a contribution from the NHS towards their care. So we also expect there to be a 1.4 to 4.4 million pound increase in NHS income received. And then finally, paragraphs 41 and 42 outline two areas of growth that are not related to demographic growth, and they are related to regulatory inspections and the requirements that have come out of those inspections. So the first of those was the assessment by the National Archive of the Record Office, and members will recall that we were given a provisional accreditation pending improvements to that service. So paragraph 41 details growth required to improve that service. And of course we had the CQC inspection of adult social care, and paragraph 42 outlines the growth required to meet the requirements of the adult social care inspection. So I'll leave it there for any questions.
Thank you very much, John. So we've covered growth, which is pages 17 to 20 in appendix page 35, covering paragraphs 23 to 42. Do you have any questions? Mr. Innes, we'll start with you first.
Thank you, Chair. I'm referring to page 18, item 27, which I think Mr. King, who's no longer, well, there he is, referred to previously. But I'm really picking up on the point that he made. When I look at the increase per user over the time period put in there, I'm estimating about a 41% increase per user, where inflation over the same period was 21%. Very interested in the views on why we almost see double the increase in cost versus the actual rise in inflation. And interestingly, if you look at between April 24 to now, we've seen a 12% increase in cost. I guess that's because of the national living wage being higher than inflation, but I would like to know just what's driving that.
Short response is yes. So The rate of cost increase or inflation in adult social care doesn't run at the same rate as general inflation, and in fact runs at 2 to 3 times the level, and it has done for the last number of years. Partly that is, I suppose probably the biggest driver of that is the minimum wage increases that we've seen over the course of the last few years, and they have outstripped inflation every year, as you're probably aware, for at least the last 5 years. So that's the biggest element of that. What you will see when we bring the use of resources report in March is that whilst inflation is running at probably between 12 and 14% per annum in social care, it is running at a lower level in Leicestershire than it is nationally. But it's still above what you'd expect to see in terms of general inflation. And mainly that is due to wage inflation. Anything else you want to say?
Probably just the only other item is the government brought in increased higher national insurance contributions. So that was also something that fed through into the higher rates that we had to pay to providers who were experiencing that added cost.
Mrs. Page.
Thank you, Chair. Page 19, paragraph 30. First of all, there is a reference to the introduction of the Fair Outcome Panel. I haven't got a clue what that is, so it would be nice if you'd explain that to me. And then it refers that originally it has, reduced the numbers of placements, etc. But then it says now the placements have slowly risen again. So how does that dovetail? It doesn't make any sense. Just talk me around that for my own sort of peace of mind. Paragraph 33, we're talking, or rather the G8 learning disability demand. Well, taking into consideration what Councillor King mentioned earlier in relation to the older people demand, it's risen 3 times. So has this amount, or it will rise by 3-folds. Now, I can't get my head around it. While I appreciate that with older people there is a demand, and quite a lot was said, but it is limited. If we're talking about learning disability demand, to me that could mean cradle to grave demand, and it is the complexity. Now, I don't know whether Google lied to me, but Google said there are still thousands of adults which are undiagnosed and could come into the stream, who have ADHD and other things. So, I would like to see a report in future that talks us around the demand, the severity, how we're going to manage this, and how we are getting on, how we can evaluate the risk or bring people back into the mainstream. So, prevention, cure and whatever. So anyway, talk me around that, because it leaves me a little bit, I find it's just too simple to say there is a demand rising from 3.8 million to 12 million, because it could be, in my opinion, far higher. And my last point on this section is the G14s, the digital preservation and storage, it's decreasing. Why is it decreasing? Does that mean, there will be a sort of scale back? Will we not see the outcome as quick, or is that just, being efficiency? Because, I think it's very important that we are pushing ahead with that. Thank you.
Okay, so we'll go backwards if that's okay. So we'll start with G14, the archive. So the TNA, when they came and assessed us in 2024, said two things. One was that we didn't have sufficient storage capacity in the archive, which obviously we knew at that point. We have an archive that has been at capacity for some time, and it's in a building which is not really fit for purpose at the moment. They also said that we needed to have a process by which we could store what they call digitally born records. So whilst we do digitize our records, we do convert records into digital format so that people can access them in that way. Some records are created in digital format. So they never have a hard copy, if you like. They never have anything that sits behind them. And we didn't have a process for storing those which the National Archive thought met their requirements. Effectively, what we did was we used the County Council's IT system, and they said that wasn't appropriate. They needed to be a separate process. So we've been working on those two things. We do now have a suggested way forward in terms of the archive, in terms of increasing capacity, and that way forward is to store new records and some of our existing records off-site in external storage. And that will relieve pressure on new records coming in, and over time we will be able to move some of our existing records, those that particularly aren't accessed regularly, into external storage. Obviously that comes at a cost. We have to buy that storage, and it comes at a cost in terms of having to catalogue everything in order to move it, and then we have to be able to retrieve it, and that comes at another cost. So it will cost ourselves and our partners in order to do that. And we do have a solution for the digital storage, so that is all in hand. In terms of the learning disability growth, so what drives growth in learning disability services is essentially two things. One is there are people who come into adult services when they reach the age of 18 and require adult social care support. And as we've noted in the report, that number is increasing over time, and we expect that it will continue to increase up until 2030. And then it may well decrease, and that's to do with birth rates. So the birth rate peaked some time ago. It's now going down. But having peaked some time ago, those children are now working their way through the school system, and they will hit us over the course of the next few years. But by 2030, that number might start to decrease because the birth rate started to go down 10 years ago, whenever it was. The other element of it is that, again, happily, people with learning disabilities are living longer. Only, a few years ago, 10, 20 years ago, people with learning disabilities tended not to live often beyond the age of 60. But many people do now, due to advances in healthcare and social care and other protective factors. So obviously that means that the demand overall goes up every year. In terms of those thousands of people who might hit our books, it is absolutely a fact that there are numbers of young people and adults, I have to say, not just young people, who are potentially missing a diagnosis of autistic disorder or other, as you said, ADHD or other disorders. That said, that doesn't necessarily mean that they will require social care services or that they would be eligible for social care services, because social care eligibility is not based on diagnosis or medical condition. It's based on need. So whatever your diagnosis, whatever your medical condition, you go through the same assessment process in terms of whether or not you have needs which need to be met by social care services. So just because a person gets a diagnosis doesn't mean that they will be eligible for our service. Going back, the first part of the question I think was around the Fair Outcomes panel, and Tracy might want to answer some of this because Tracy led that panel for quite a long time, actually.
So the Fair Outcomes panel was introduced in September 2023, and it was part of our work to help support a process for demand management. but also looking at how we maximise the independence of individuals. So the Fair Outcomes Panel also builds on the target operator model that the department introduced back in 2019, 2020. And one of the things that the panel does is takes cases on a day-by-day basis and will scrutinise the request for support. So what it seeks to do is if somebody requires domiciliary care, we would look at should reablement be considered in the first instance to maximise that person's independence and reduce the cost on our demand-led budgets. We might look at alternatives from residential care into extra care. So it's again supporting that level of independence, but driving down the cost for the department. And we record those costs on a day-to-day basis, and then they're projected into kind of financial savings on behalf of the department.
Every case.
It's every case, certainly in my service area, where the demand-led budgets are driven by older adults. There's a supported living panel, which is also held related to learning disability services. And if cases are not taken to the Fair Outcomes Panel, then they're scrutinised through what's called a group supervision meeting, which is part of the target operating model that exists across the whole of the department.
If I may come back. So obviously that has been worth it's while, because it identified efficiency services and whatever, but then it says over the last 2 years placement numbers have slowly risen of levels observed. So how did that, just talk me around that as well?
Some of that obviously relates to the number of self-funders that are now reaching the threshold in respect of residential care services. And again, what we would look at is, although people are placed in residential care, could we look at an alternative to support them to, say, move back into extra care? The other thing that's happening, we are seeing increased demand in respect of the pressure on hospital discharges for people who've got increasingly complex needs post-discharge. So people that might have unresolved delirium that require a period of assessment. So they're placed into short-term residential care beds. But certainly the process that follows them out of the Fair Outcomes Panel would be to look at ongoing assessment for eligibility and whether we could get that person back home into other alternatives for accommodation, for example. So it's not just one component of the Fair Outcomes Panel, there's follow-up work that's undertaken.
Just let's come back on that. So to me, it seems that it is a really, really good process, because not only does every individual gets the best evaluation of, and you can see where there comes soft, savings and where there's additional need. So just for my own, is this something we have introduced here, or is that a national model? Or because I think it is really quite fantastic now you're telling me the detail.
So it's not a national model. We're not the only authority to have that kind of process in place, but it was something that we introduced locally, and it was specifically introduced in 22-23 because demand was becoming unmanageable at that point. And if you recall, we would be sitting here in 2023 saying that we had a projected overspend of 17 to 20 million by the end of the year, which obviously is not acceptable, and therefore we introduced that process. It is a bit of a sledgehammer. So effectively what we did was we took away any delegated authority to spend anything without going through that kind of process, and every single piece of care that was commissioned had to go through that process. And that panel was managed by Tracy and Inderjit and other senior colleagues, and it ran every single day, and it took nearly half a day to go through all of that. It's not something that you want to do on an ongoing basis. It's not a good way to run a business. You want to give people accountability. You want to give people responsibility. You need people to make professional decisions. So gradually over time, we have relaxed the requirement for all care packages now to go through that process. And we have given managers back some responsibility and some accountability. And what we do now, other than Tracy's service area, so in Tracy's service area, they still do it, but in other areas, they don't. And what we do now is we track the decisions that those managers are making against those decisions that were made during that panel year. And we track to make sure that those decisions are still in line with what would have been made had the panel been in existence. I think we're able to sort of assure ourselves that actually the decision making is now where we'd want it to be. So it's not only was it a process to manage cost and demand at that point, it was also a learning process throughout the organisation, so that people learned what was expected and going forward are now making the decisions that we'd expect them to make. So yeah, it is an incredibly resource intensive process. It did what we needed it to do, but it's not the way you want to run a business.
Sorry, can I just pick up on one more element as well? What we seek to do is use information related to things like hospital discharge at strategic level, so with partners in the NHS, to say where we've looked at and scrutinised packages of care or requests for residential care, what we need to do is to work to improve that level of independence when people are discharged, because that's driving up our costs. So it's not just used at a level on a day-to-day basis. We provide that further information about health and social care spend.
Mr. King, you've got a question.
Yeah, thanks. Mrs. Page has covered some of what I was going to ask, but just coming back to the forecast demand increases, Chair, and the report assumes demand growth of around 2.1%, given that you've got this essentially, let's call it what it is, rationing system in place. But just older people alone, demand is set to increase by 329% in 3 years. So what happens to the MTFS if the demand reverts back halfway back to the 3.6 level of growth that you were getting before? What happens to the MTFS and all these forecasts of growth? Because they're all predicated on the global 2.1% increase. But if that increase is out, because we've just heard you've allowed managers to have more kind of control over the services rather than being controlled by this panel, fair outcomes panel, what happens then? What happens to these forecasts? How much are they going to be out? Because there's a significant contribution to the £23 million deficit next year and the £49 million deficit the year after. So if these figures are out by a very small percentage, then that's going to make a massive difference to the MTFS gap, given where the administration has set its table for council tax, and also on the use of reserves. So I'm just really curious, Chair, as to what the level of error that we've got here, and what we think could happen, given that if you look at the graph and the number of service users, having had a period of, broadly speaking, 2 years where growth has been sort of driven down, then it's gone up a bit, driven down again. But now, certainly in the last year or so, it looks like that growth has been rising for all sorts of reasons, I'm sure, and it is set to go past the peak of September 23. So that the concern's got to be that growth level is, I'm not an expert in graphs and gradients, but it looks very similar to the rate of growth that it was before. So I'm just wondering if that's what we're looking at, and if that's the case, then potentially all the figures in this budget forecast are pretty ropey. So I'm just wondering, and I'd be grateful if we could get an answer on that. Thank you.
Well, we're not fortune tellers, so we can't see the future, and we make our best estimates based on the calculations that colleagues in finance provide for us. We can only work on the information that we have at the time that we make those forecasts. If those forecasts are wrong, then we will have to address that. They could be, too high. They could be too low. Similarly with the savings, when we get onto savings, what happens if we don't make the savings that we're proposed to make? All we can do is work on what we know today, forecast that into the future, project what that will look like. But if it's different, then we will have to address that at the time.
Thank you, John. Yeah, I'd just like to say it's hard to judge how long a piece of string is. You never know when you're going to win the lottery, and you never know when you're going to be bankrupt. So, you know.
If I can just come back, sorry, no, I understand that, but equally, Chair, we're not talking about the lottery, are we? So if I can just, I've got a further question, if I may, just to go on to the children's growth, the learning disability growth, the children with disabilities moving into adult services. It says in the report, it says you can't quantify the numbers, but surely we know how many children have got learning, with disabilities that we already have in Leicestershire, and so therefore we must have some idea of how many children are likely or anticipated to be requiring our service or support in when they become adults. So I'm a bit surprised why we haven't costed any of that, because on the one hand you say it's increased birth rates, but we're saying we can't quantify it, and that's concerning, because what sort of unknown cost quantity are we talking about here? This is another huge pressure potentially for the authority that we currently don't seem to know, and that again could make the MTFS figures even worse. We don't seem to have any contingency in the MTFS for anything like this, or what I was asking about earlier. So I'm just wondering if we can get a clear answer about when we might think we might get an accurate, when will we get some idea about these sorts of numbers in paragraph 35. Thank you.
So the 3.8 million in 26-27 and rising to 12 million in 29-30 includes making a provision for those young people. What we're saying in paragraph 35 is that each year we will need to look at that cohort and refine that number, because we don't know. So if we've got somebody who is currently aged 12, 13, 14, we know when they are going to get to 18, so we know when they will potentially need adult services. We don't know what provision they will need at that point. We don't know whether it be residential care, whether it be supported living, whether it be home care. We don't know whether it be the size of the package. We don't know what the cost of that package would be at that point. So we can make some provision, and that's built in to learning disability demand. But the point that's being made at paragraph 35 is that we can't firm up those figures until those people are much nearer the age of 18. So we know how many people roughly, we know how many people over the last 2, 3, 4, 5 years have transitioned from children's services to adult services. We know how much that's cost us. We make provisions on that basis. But each year we have to refine that as we go forward, and those numbers could change, is effectively what we're saying.
Yeah, so thanks, Chair. So that's, that budget area is a 315% increase over the MTFS, according to the figures you've put in here. Obviously, you've got no breakdown of how many. You've just said you've got some idea of numbers. You've made some assumptions based on the numbers of young people that have moved from children to adults over the last 3, 4, 5 years. Well, we haven't got any of that information here, so I've got no idea what assumptions have been made in working out these numbers. I mean, you're telling me, but it's not in the report, so I've got no idea what assumptions have been made, what sort of numbers, what the average cost of those packages are, or anything, and what the breakdown of the 3.8 rising to 12 million by 29-30 is in between the different groups of learning disability demand. So again, it's kind of difficult to know what the pressure is coming from, and so it's very difficult, Chair. Thank you.
Thank you, Mrs. Broadley.
Thank you, Chair. Where do I start after that? Learning disabilities forecast demand. I can understand why you cannot come up with a figure for the future. Has has it been taken into account the fact that children with learning disabilities tend to, well, because the government says you send your children to school or to a special school or whatever, when you reach the age of 18, you either, if you have a mild learning disability, you might get a job, you might do anything. But there are a lot of adults, young adults with learning disabilities that don't actually do anything. They remain with parents. So has it been taken into account that, again, you can't give us a figure because who knows, but has it been taken into account that there are adults with learning disabilities that are being cared for at the moment by parents, that they are not having any services from anywhere? The parents have done it, but obviously we're an aging population, and these adults, when something happens to the parents, have to then have a package. I'm presuming that this has all been taken into account, and I just wanted to you to clarify that you have taken it into account, because that's what anybody would do. You're talking about the team that Tracy did. What is put in place for the division of health and social care? How do we know that the people that we are serving are social care? And the reason I'm asking, as I think you're probably well aware, when my daughter was assessed, I was told that it was half social care, half health. I knew it was health. There's no way it was social care. And I argued and appealed, and she is funded by health, not social services. And I'm thinking, can others challenge that? You know, do we challenge? Because obviously nobody from social care challenged the decision that was made for me, well, for my daughter, but I challenged it. And I just think, if health budgets are just as bad as social care budgets, but what is in place to make sure that whatever budget you're on is the correct one, so that, you know, some of the health budgets might be ours, some whatever, but it's just how it's worked out, and whether we do challenge some of the packages that come through. Thank you.
Yes, so in terms of the first point, yes, we do take into account people with learning disabilities coming to us in later life, as well as those who come through from children's services. So what we do is we look at the numbers of people who have entered the service over the course of the last 12 months, and we project forward from there. In terms of the health, you'll see when we get onto savings, there is a particular saving line which relates to continuing healthcare and funded nursing care. And it is in relation to that very point that you've just raised, which is, how do we know that we've got the right people receiving the right care, funded by the right organisation? It is the case that a few years ago, we raised significant concerns with NHS colleagues that there were fewer people in Leicestershire being funded through continuing healthcare than in other areas of the country. We did a piece of work, and we are continuing to do a piece of work with health colleagues. It is now the case that we are much more consistent now with the national average. So if you look at the number of people who have health funding per 50,000 population, we were very low. We are now in the mid range, that average. So we're seeing quite a big steep increase in the numbers of people receiving continuing healthcare. That in itself is bringing further difficulties, because now our NHS colleagues are under some significant pressure from NHS England, who are saying, well, why has there been such a big increase? Why is your increase bigger than everybody else's? Well, it's because they started from a much lower point, but got to go through that process. We are still working with health colleagues on funded nursing care, because we still believe that there should be more people in Leicestershire who are awarded funded nursing care. than is the case, but we are still working on that. In terms of disputes, we have a process. We have a dispute resolution process. So there is a process by which we can challenge those awards. But what we don't have is a legal right to challenge in the same way that individuals do. So individuals, as part of the National Continuing Healthcare Policy, individuals can challenge the NHS around that. We don't have that same legal right of challenge. But we do have a process in place where we can have conversations and discussions, and we can take evidence to a panel. But we can't take it all the way through in the same way that individuals can. No, which isn't to say we can't support individuals.
Got no more questions. We'll move on to the next section, which is savings, which is pages 20 to 28 and paragraphs 43 to 88.
Thank you. So we are going now through the details of savings, which is set out in Appendix C, which totals £7 million in 26-27 through to 13 million over the next 4 years. The first of those is increased income. This relates back to the conversation we had earlier around income from people who draw on support. We make a provision every year that that income will increase, simply due to the fact that people's pensions increase, and if people's pensions increase, we can increase the income that we derive from individuals because they have more disposable income. The next one is in relation to assistive technology. This is the end of a 4-year MTFS line that we have had in the MTFS for the last 4 years. So this is the final elements of the saving from implementing a new assistive technology service. Paragraph 48 relates to the Better Care Fund, which is the funding that we get from the NHS. And that is uplifted in line with NHS inflation every year. So we know that we will get an uplift in that income. Transforming care, extra care is a saving related to our current extra care provision and making more use of that extra care provision for people with more complex needs as an alternative to residential care. Continuing review of contracts across all areas is a saving built on looking at our existing non-care related, non-demand led related contracts. So these are contracts with organisations such as advocacy or other services which aren't demand led. So some of our smaller contract areas, and looking at whether we could make a saving against those contracts. The next one is a sort of housekeeping efficiency. So looking at last year's expenditure, looking at the budgets, looking where we didn't spend all the budget and whether we can therefore trim those budget areas going forward. Reviewing in-house short breaks is the opportunity to utilise our existing in-house capacity more effectively. So that would enable us not to have to purchase care externally and would also potentially bring in income if other organisations wished to use our short break services. Review one-to-one support in residential care. Again, it's looking at making sure people got the right support at the right time and that people don't have more support than they require. Increased health income is the one we've just spoken about in terms of continuing healthcare and funded nursing care. Reviews of fees and charges is again a bit of housekeeping, making sure that we are up to date with our fees and charges and that we are charging an appropriate amount. The light bulb service contribution is in relation to the partnership that we have with the district councils around the provision of housing support and adaptations, and it's looking at moving in to the light bulb service an existing provision that we have for ceiling track hoists. So that would become part of the light bulb service. Reviewing direct payments and processes is effectively what it says on the tin there. So we have a team that have been put in place to monitor expenditure, ensure compliance, identify where there is unspent direct payment funding. Social care data quality is another housekeeping one. So this is looking at our current liquid logic system, which is the case management system that we have, and the financial systems, making sure that we've got all of those commissioning lines, and there are thousands of them, making sure they've all been updated appropriately, making sure we are effectively achieving all the income that we should be, and that we have the right spending lines. Strategic commissioning efficiencies is relation to a team of people that we had in place to deliver our social care investment plan, which is around accommodation-based support. That team is now being merged into our wider commissioning team, and that's yielded a saving. The next two relate to current procurements, so the home care procurement and the community life choices procurement processes, and they relate to savings that we will make through reprocuring those services. And then the next block of 4 or 5 relate to a review of prevention services that has been in place for the last 18 months, 2 years, where we've been looking to highlight services that we may be able to undertake differently. And the first is a review of home care packages. So this is an early review team that we put in place, which seeks to review people's care after the first couple of weeks, to make sure that people have the right care. The second is supported living, where we are looking to undertake targeted reviews of people in supported living services. Hospital discharge and reablement is looking at the hospital discharge pathways, making sure that we don't have too many people going into 24-hour care, and that people have the right support at home. And then the final one there is prevention, pathway to adulthood. So this is the people moving from children's services into adult services, and ensuring that we have a smoother transition process, and that we are able to maximise people's independence when they reach adulthood. And then the final one is an increase in reablement capacity, which we know that there are people who could benefit from reablement, but who don't have that opportunity because we don't have sufficient reablement capacity. So we are looking to increase our reablement service, which will mean that we can potentially offer that service to an extra 600 people a year. That's all the social care ones. There is one saving related to the community and wellbeing services, which again is has been on the MTFS for some time, and it's to implement the merger of all the collections together with some of the archive, which will bring an efficiency in terms of the management of those collections. There are then, from paragraph 73 onwards, a number of areas where we are still considering and doing work on potential savings that we may well bring forward, but they're not ready yet to go into the MTFS. So those are looking at improvements to the financial assessment process, streamlining the process, making it more timely, ensuring that people have information about the contributions they need to make at as early a stage as possible, which potentially reduces debts that people build up. We want to develop extra care in parts of the county where we don't currently have any. So we have 2 or 3 sites that we are working on to see whether we can get extra care developed on those areas, which would be an alternative to 24-hour care. We have an AI pilot which is running in the department at the moment. So it's a pilot looking at how we undertake our assessments and reviews using AI to streamline that process, and to ensure that we have a more consistent process and a more timely way of getting people assessed. And again, that could bring forward efficiency savings. And then we have the carers review, which is currently underway, where we are looking to develop a new carers strategy and a new carers service, and we'll be bringing a report to committee in March on that. And then finally, I think on this section, we have the efficiency review, the corporate efficiency review, which is the review that's touched on earlier, which the administration have initiated with Newton to look at how we can bridge the financial gap on the MTFS. And alongside some of the corporate activities, Newton are also working with the department to understand and to identify if there are any opportunities that might exist within the department. And we've noted at paragraph 85 5 areas that we are working with Newton on. These areas are, again, not ready to be brought forward into the MTFS at this point, but they are areas which might feature in the next MTFS or be brought forward in year in 26-27. So I'll stop there. Thank you, Chair.
John, at this point, I'd like to invite any further questions or comments from members of the committee, the Cabinet Lead Member and officers of the revenue budget proposals. So, are any questions? Mr. King?
Yeah, thanks. Okay, so having had a quick look at this, so when you match savings against MTFS gap and growth, there's a gap, a net gap of 17 million by 29-30, basically of where we are now. So looking at what you're predicting based on all the assumptions and all the weaknesses and strengths of that, and based on the savings that are in the report, by 29-30, there's an additional gap of 17 million. So going back to the MTFS overall of 100 odd million by 29-30, that means broadly speaking, approximately 17-18% of that MTFS gap across the county council budget will be due to adult social care and communities. That's the logical deduction that one can make from that. So just trying to understand in these savings, now some of these savings are very small, 100,000 here, 100,000 there, and I'm not knocking that, but also that means they're also incredibly sensitive and actually might not be deliverable equally if there's an uptick in growth in demand. It could be that some of those services aren't actually cash, some of those savings aren't cashable. So I'm trying to understand from some of this whether because there's a difference between increased income, which is actually money coming in, and actually not spending as much money on something. And I'm trying to understand, particularly on the prevention review ones. Now, prevention, obviously, we're all told prevention's better than the cure, Chair, and that preventing people requiring support is infinitely less demanding on them. It's equally less financially demanding. But I'm just trying to understand the prevention review. Are they savings from the prevention budget or savings from the adult social care expenditure side of things that we're expecting to make? So again, this is assuming that we can make those. So I hadn't seen a growth item anywhere for a prevention review. So is there an increase in the amount of prevention activity we're going to do, or is this just something that's come about from because have we found a different way of working basically to enable that? I'm just trying to understand how that's happening if we're not putting more money into that area. So I'd just be grateful, Chair, for if that could just be explained a bit better. Thank you.
So yes, so it's highlighted as prevention review, which is something that, as I said, was started a couple of years ago by the previous administration. It's not, the savings don't derive from a prevention budget per se, they derive from reduced demand in the demand-led services. So for example, the first one there, the review of cases, the early review, the saving derives from reductions in home care packages, in domiciliary care. So if we say somebody is discharged from hospital with 4 calls a day, home care calls a day, we go in within the first couple of weeks. Person now at home, they're more settled, they're in their own environment, they're familiar with, they've got support from their partner, whatever it happens to be. We can reduce that level of home care provision from 4 calls a day, maybe to 2 calls a day, for example. Maybe not, maybe might not need home care at all. So that's saving is derived from the home care budget. Similarly with the supported living, people going to supported living with complex needs, they'll often be transitioning either from home or from hospital. They'll need quite a lot of support because we're talking about people with very complex needs, people with learning disabilities, mental health needs, and those packages will be put in. But it might well be that over time they become. We would hope that they would become more independent because they're in independent living, they're learning life skills, etc. So over time, you can reduce some of that level of. So those savings don't derive from a prevention budget; they derive from the demand-led services. That, but what we're trying to do is look at how we can promote people's independence and prevent people needing social care, formal social care support over a period of time. So that's where they derive from.
If I may, Chair, I mean, on a personal level, I welcome that, because I think anything that we can do to prevent people from acquiring institutionalised care, I think is a good thing. Absolutely, and it's less invasive, it's less costly, and it's certainly for all concerned. So anything we can do to do that, I certainly welcome that, and I certainly think that's a good thing. What I'm concerned about is whether these figures are fragile, in the sense that if there's an uptick in demand that we discussed earlier, which currently we're anticipating this just over 2%, but if that starts swinging back to slightly increased level, how vulnerable are these savings, I can put it like that, to an uptick in that level of demand, given that we've just got the broad brush demand level of what you've shown us. So that's the bit I'm trying to understand. How sensitive are these numbers to that kind of, if there's a slight uptick? It wouldn't have to be much, I guess, but gratefully if you could just explain that. Thank you.
So these particular savings shouldn't be sensitive to that, really, because these are based on existing cohorts of people rather than any new demand. What we might anticipate is that if there was further demand, then we would expect to see an increase in these areas of saving to offset it, because if we got more people coming in receiving needing home care, then we might need to review more people, and so there would be a netting off, but they're not sensitive in that sense.
Mrs. Page.
Thank you, Chairman. Couple of points. First, the paragraph 44, representing the division that allegedly has the largest aging population. I know that there are a lot of pensioners and people who are capital rich but asset poor. There is a lot of hidden deprivation, and I feel in a way that in some cases the pension people work 35 years for is less than some people receive in benefits. And it's worrying to see that that inflation rises for pension, which is not relative to the actual, small amount they are getting and they're paid in for. So my worry, it is the first sentence: in benefit payment should be provide additional chargeable income. So what would that be, and how, how could we ensure that we take into consideration the, rural poverty, etc.? Question number 2 is paragraph 61. It refers to the business case to improve efficiency of 200,000 from light bulb. Now, talk me through that, because later on, I think on page 29, because we know Blaby is delivering it for all of the districts and whatever, and there is a figure of 5.5 million that is being passed on to districts. Maybe it is worth at maybe a later date also to look at a report of the effectiveness of the light bulb service and how it dovetails in with us. And then I've got just two more minor points. Point 77, artificial intelligence worries me. It's only as good as what you put into it. And I've said it many a times, if we as an authority going into using too much AI, are we losing the human factor? Because we've got to be very, very careful. I know myself, you say something and then it says, well, no answer, and you're going round and round in circle. So are we making sure, especially because we're talking adult social care, we are talking about some people with worries, concerns. Linda mentioned it, how, previously, how you're going round and round in the system. So you get my drift. And then point 82, last but not least, yes, you set out the Newton the basics, but it says there is a report coming. Will we see it, in the new year? Where is it going to? Give me a bit more information on that, because quite looking forward to that. Thank you.
Okay, I'll deal with a couple, and I'll probably hand over to Tracy, particularly around the AI, because Tracy's leading that AI pilot, so she'll be able to respond more fully than I can. In terms of chargeable income, so social care charging policy is such that we are required to charge for residential care services. Not. It's for domiciliary care services, charging is discretionary on local authorities, so we can choose not to. Or we can choose how much we want to charge. This authority has taken the view that we will maximise the charge that we are able to apply. What that means is that when somebody comes into services, we undertake a financial assessment. That financial assessment is based on their assets and income. By law, we have to leave people with what's called the minimum income guarantee. So whatever their income is, they have to have a certain amount of income, which the government set as a minimum income guarantee. And then on top of that, there are some provisions for things like housing costs, council tax, other payments that people might have to make, and there is a small provision for disability-related expenses. Over and above that, we can then charge up to the cost of services that people. So whatever people are left with, up to the cost of their service, we can charge them. So, because of the triple lock on pensions rise each year by the maximum amount or the minimum amount, or however you want to describe it, within the triple lock. So as those pensions increase, that maximum amount up to the cost of the service. So if somebody's got a service that's £400 a week, and they are, after we do all of our calculations, they are left with £200 a week, we can charge £200. If their pension then goes up to £410 a week, we can charge £210. Now that might seem unfair, but that is the way that the system works, and that is the way that we charge. So that's why we say that if pensions increase, we will see an increase in our chargeable income, because we can charge up to the maximum of people's costs. In terms of light bulb, So Lightbulb works as a partnership for major adaptations and for support with people's housing. And as part of that partnership, as a county council, we fund 55% of the partnership, and the district councils fund 45% of the partnership. The Disabled Facilities Grant for major adaptations goes straight over to the districts, and they provide the funding for those. And we provide the funding for minor adaptations and for things like ceiling track hoists and stair lifts. We've been discussing with our partners in Lightbulb that we think that the ceiling track hoists should be an allowable expense for Disabled Facilities Grant, because it's a permanent fixture to people's properties. It's a major adaptation in many ways. And partners in Lightbulb had agreed that from 26-27, they would bring ceiling track hoists into the overall Lightbulb partnership contract, which would mean that whereas at the moment we're paying 100% for the, in future we would only pay 55%, and the districts from their Disabled Facilities Grant would meet the other 45%. AI, do you want to explain the AI?
So the current pilot relating to artificial intelligence and care and support assessments, as well as mental capacity assessments or range of assessments, is that we have got about 35 staff across the department that will seek to engage with people and gain their consent to use a recording device rather than writing notes when they're in somebody's property undertaking that care and support assessment. And the aim is that it's less time for officers to then input data into the Liquid Logic system, which means hopefully we'll see increased throughput of the work that people are able to do, so not double keying information, if that makes sense. But it is only done with the consent of the individuals. We've got a range of information that we're looking at around timeliness of assessment, feedback from people that have utilised that new way of working. Did it improve their engagement with the work, or did they get information in a more timely manner? So it's a pilot running for 12 weeks at the current time. And then what we'll do is evaluate it and look at whether we roll that out across all officers within the department. But just to be clear, it is only with consent of those individuals that they want to be part of that process.
Newton, yes. So we're having conversations with colleagues in Newton around what might be possible going forward. What they're looking at is what we've currently got in our MTFS. So they've looked at all of those lines that we've just been through, for example, and they're looking at whether or not they think that they're reasonable or whether they could be stretched or potentially stopped. Alongside of that, they're looking at any other area where, having worked with other authorities and bringing the experience that they've got nationally, whether they think there's anything that we haven't thought of. The biggest area potentially, so most of those, as you'll see, if you look at that sort of under paragraph 85, most of those are things that we've already talked about or are already on our MTFS, but it might be that they will say, well, you might be able to go further, or you might be able to do a bit more, or what have you. One area that I think potentially is different is the first one, prevention. So that is, it says there, proactively identifying residents who are at risk of a crisis, delivering targeted support, which might prevent them from requiring formal commissioned care. And in that space, what Newton are doing is they've taken all of our data. They're looking at all of our data, looking at why people approach us for care. Why, when is it that people come to us? What's the nature of the crisis that causes people to require social care? What's the period of time over which that happens? And then they're going to work with us around looking at targeted support for those areas that they think would have the biggest impact. Now, we haven't had that conversation with them yet. So they're still doing their bit of the work, and then they'll come to us and we'll have a conversation. But potentially for things like, for example, they might pick out in other areas of the country, they've picked out that falls are the biggest issue that cause people to require social, or to first contact the social care department. When a person starts falling, when they start getting unsteady on the feet, that's when they or their family say, oh, I think they need a bit of support. So in that sense, can we intervene at an earlier stage with people when we know that they are in that position? If they've had one fall, maybe they've been to the GP, maybe they've been to the hospital, whatever, before they have their second and third, which tends to be when then they come to us, could we intervene earlier with them? Is there something we could do which would potentially mean they could be more independent and wouldn't require our services? So would equipment at an earlier stage, for example, that help? Advice, information, would that help? Other areas might be looking at people with particular conditions and or admission. So we talk about discharge from hospital, but actually the real key is avoiding people going into hospital. Because what happens is when people go into hospital, they invariably come out with a higher level of need than they had when they went in. Although people go into hospital to get well, obviously what happens for a lot of people is that they go into hospital and they, without needing any social care, and they come out requiring social care. If we can stop people going in the first place, can we identify those people who might be at risk of going to A&E, might be at risk of requiring a hospital admission? Can we get to them earlier? Can we do something more proactive and preventative? So that's the work that Newton are looking at. And they have particular tools that they use. They have particular risk management matrices that they use. And then they'll come to us and they'll say, well, these are the cohorts that we've identified. Is an opportunity to do something differently upstream that prevents people then requiring social care downstream.
So what's the timescale and when will we all see the outcomes?
I think the timescale is pretty tight, actually. The members might want to answer, but I think
it says early 26.
Yes.
So, you know, does that mean is a report coming out in March, April? Will it be public? Will it be shared? Please allow.
If I may, Chair. We're concentrating initially on early fines for this year's budget. What we're going to achieve in time for that, I don't know. The whole process, I think, is looking at coming forward April.
If I may. So early fines, you're planning to work into this budget because it has to be done very, very done. And then a second bite at the sherry for April, and then that to be implemented in the following year. Do I understand that correctly?
Yes, that's right.
Mr. Innes, before you leave, is it not?
Unfortunately. I just wanted to build on what you said. This stopping people going into A&E and then having the requirement to come out with some sort of social care. We've been having in another committee, the health committee, having a wrangle about GP care and that sort of thing. There needs to be some connection there, I think, to say, look, how are we working together? But that's just a secondary point. The other point I wanted to make was, if I can get it right, item 65 and 66, you probably guessed I would pick up on this one. Procurement savings. I think from my perspective, I think you're underplaying the savings. I think if we can build on the work that we did earlier late last year, I think there's a lot more savings to be had in the procurement side of what we're doing. And I just, in 65, it doesn't refer at all to the work that we did. So is there additional savings to come through from that?
Yes, is the answer. So 65 and 66 are only based on what we can definitely say will happen, or with, well, not definitely, but with pretty good level of confidence. So the home care one in 65, for example, is simply based on the boundary changes to the zonal boundary changes, which we calculate should be around £200,000 of saving. What it's not based on is any of the savings that will accrue from the variable pricing and the ceiling and floor pricing mechanism. And the reason for that is, obviously, when we wrote the report, we're still going through the evaluation. of those tenders. And we don't know yet what those price points will be. We won't know until after the MTFS has been set, after the budget's been set. But we would expect that there would be a further saving coming forward in next year's MTFS, which would relate to those price points.
Thank you. If there's no more questions, we move on.
Yeah, please, Chair. I've just got additional point I wanted to raise. So thanks for the answers that you've given so far. So just to build on a couple of things. So obviously the prevention agenda requires staff that are specialists in working. So if you can increase activity in that area, presumably we've got staff then who've got capacity, current staff that we employ to do this activity, or have we got to hire additional staff, specialist staff, to enable and to increase the capacity in reablement? Because approximately half the savings that you're talking about are predicated on this reablement, which I note in paragraph 83 is the initial, this is one of the ideas that's come out of the Newton review. So I'm just wondering how realistic is this, given all the staffing pressures that we know about in adult social care, reliance on agencies and national living wage, costs that we talked about earlier, national living wage shocks and things like that. So I'm just wondering how that is, whether that's realistic, and that's what I wanted to ask about. The second thing is just about this Newton review. Now, Mrs. Page did go into that a bit, but what I wanted to ask the cabinet members, maybe they can answer this. In the report, in paragraph 79, it says a step change in approach is required. A step change. That's a pretty radical thing to be saying. That's indicating a very major change is required. I'm not sensing that from what I'm seeing at the moment. And obviously, if some of these things under item paragraph 85 were to occur, but prevention agenda, Chair, is not particularly quick to implement. I mean, we sat in a previous meeting where I believe there was something that the team were looking at for a couple of years, and we still hadn't got a sense of how much that was going to save or what difference it was going to make. So I'm just a bit concerned that this it all sounds good, but how much of this is actually going to be deliverable? And on top of that, we've got to add the LGR issue, which is obviously going to be thrown into the mixer as well. So I'm just concerned, Chair, that we're talking about saving an additional, based on the growth and savings that we've already got, 17 million to equalise the adult social care budget over the period of the MTFS, based on all the current knowns for demand, etc., and all the unknown demands that we also know about. So I'm just concerned how robust is the budget that we're seeing. Is this a holding budget because you're basically holding out for the Newton to come up with solutions that may or may not be deliverable over the course of the MTFS? So that's what I wanted to say, Chair. But the question really is workforce. How do we have the workforce, or are we going to have to hire additional people or retrain them to enable to deliver some of this agenda? Thank you.
I suppose the answer is we don't know, because, as I've already said, we don't know exactly what the areas are that Newton are going to come back with yet. We've got a broad area of, if you take those areas that are on there at the moment, developing extra care housing, additional extra care housing, no, we probably don't need any additional staffing. Reviewing of people with long-term disabilities is aligned to the earlier saving that we talked about in terms of supported living. We already have review teams. We probably don't need any extra staffing. The reablement opportunity that you mentioned is the initial opportunity is the one that's mentioned at paragraph 71. So the additional 1 million for reablement is part of this work, and that's to do with the fact that we already have 30 vacancies within the service. And if we were able to fill all of those vacancies, then we could provide the additional 600 people with reablement. each year. So we don't need additional staffing for that. But if it goes beyond that, if then there is a further saving that says, and in addition to that, there is an opportunity to re-able another 600 people, then yes, we would. But we net off the cost of the staffing from the saving, which is what we do with all of our saving areas. We net off the costs of delivery before we put forward the opportunity. In terms of the prevention activity, we don't know, because we don't know what that activity is likely to be, so we don't know which staff would be required. But again, if there is an additional requirement for staff, we'd net off the cost of those staff from the overall saving opportunity before we put it into the MTFS.
Okay, we'll move on to the next section, which is health and social care integration. It's pages 28 to 30, paragraphs 89 to 100.
In this section, we are just outlining the requirement that the council has for the what used to be called the Better Care Fund is now called the Better Care Grant. This is a pooled budget between the local authority and the NHS to deliver integrated health and care services. It's been in place since 2015. And within it, there is a requirement for both the NHS and the local authority to contribute to a pooling of resources. Within that, there is a minimum contribution that the NHS are required to make to support social care services. So you'll see that the overall Better Care Fund is worth £86 million in Leicestershire. Within that, the NHS minimum allocation is 59 million and the local authorities allocation is 22 million. And then there's the £5 million disabled facilities grant. Of the NHS contribution, they have to have a minimum allocation of 24 million to sustain adult social care services. But then on top of that, within our pooling of resources and our integrated service delivery, there is another £9 million worth of service that is also allocated to social care commissioned services. And then there's an element that is allocated to NHS out of hospital services, along with some other areas around mental health services and public health services. So it's a very important element of our budget. It's an element of budget which is obviously something that we rely upon, given the size and scale of the grant. There is no indication at the moment that that grant is at risk, but nevertheless, it's something that we always like to outline within the NTFS report because it's a significant amount of income to the council.
I'd like to invite any further question or comments from members of the committee to the Cabinet Lead Member and officers of the revenue budget proposals. Mrs. Page, we'll start with you.
Thank you. This is quite a marathon, isn't it? 100 other funding resources. Now, I appreciate that that is funding that is expected to be received, but I'm not even going to ask you what War Pension Disregard Grant is or whatever. Just tell me whether these are already integrated in other service cost. Is this whatever the money we're getting here, is that the full amount paying, or is that just additional? So what I don't know is what the cost of the individual services, and why in particular I made a note when I was reading the report. Bear with me while I'm waffling, because it says the social care grant in prison is £264,000. Now, in my previous life, when I was sitting there, I went to all of the prisons, and we are quite fortunate that we've only got 2, unlike other areas, but I noticed that when we were there, and at the time, that people had, and I didn't realise that, an awful lot of social care needs. And there was an awful lot of cost, and people were aging quicker and whatever. So we are now talking a super prison about to start in, Harborough. So, a huge cost increase. So does this cover the amount? Is this additional? I mean, just, talk me through this just a little bit. Thank you.
So with regards to paragraph 100, these do contribute towards the cost of the services. There is an argument to say, do they truly contribute to the cost of the services? For example, the example that you've given with the social care and prisons grant, it's whatever the government give us. It doesn't necessarily reflect the true cost of the care.
Yes, so then with that in mind, if these costs are quite high, just going back to the prison grant, so will that be adjusted in the future? And, how do we, are we already making presentations, or how will this work?
So there's an allocation which comes out annually as part of the local authority settlement. It should, the social care prison grant was based on the prison population in each local authority area. So it is a per sort of capita, if you like, prison population. How often it is uplifted, I couldn't tell you. We'd have to look into that. I don't know, how often did they review it annually, or do they review it every 3 years? I don't really know. I'd have to look into that.
Okay, Mr. King.
Yeah, thanks, Chair. So a couple of questions. On paragraph 91, it says the framework for the Better Care Fund has not yet been published. Have we got any idea when that's going to be published?
We don't have a date as yet for 26-27. It was originally supposedly aligned to the local authority settlement, which was obviously before Christmas.
Yeah.
We haven't been given a specific date, but we believe it could be any time in the next couple of weeks, but we don't know.
Okay, and is the department indicating any changes to the framework that they're thinking about, or were contemplating, cogitating, whatever adjective you want to use?
I'm sure they are. We haven't seen the site of it. What we think is going to happen, but this is only our, this is an assumption. So what we think might happen is that they will align the Better Care Fund and the Better Care Grant more closely to the 10-year plan, the NHS 10-year plan that was announced, and particularly in respect to 2 areas. One would be prevention, and the second would be neighbourhood models, of what they're calling neighbourhood models of care. So there's a new initiative which is to develop neighbourhood-based health and social care teams to support people at a neighbourhood level. Yeah, and we think that they will align the grant to that in order to drive that integration.
Yeah, no, I'm aware. I've seen that somewhere else, mentioned somewhere else. Okay, so Chair, just a further question I had is, I mean, obviously, at the moment, the Better Care Fund provides quite a significant amount of income to the department. If that was to vary, do we have a contingency if it was to go down, or if it was to, just extrapolating what you've just said, if the situation was that funding has to be used for something different to what we've historically and traditionally used it for, then where does that kind of leave us? Because we won't have very long to react, presumably, along with lots of other social care authorities in the country, I suspect. So I'm just wondering, what do we have a contingency if it?
So you're absolutely right. It would affect not just us, but every authority in the country, because every authority in the country has this grant to a greater or lesser degree. What we've been saying as a profession, and what we've been saying through our channels to the Department of Health and Social Care is, if you want to make any changes to the priorities, those changes must be made in for the element of the grant that is uplifted, i.e. the new money. What you can't do is expect local authorities or the NHS to significantly shift the existing expenditure because it's all tied into existing services for people. So we can't just remove an element of funding. You can't just say, well, we're going to change all the priorities and we want you to spend all of the money over here.
Yeah.
Well, you can't do that because it's supporting people in residential care, it's supporting people in nursing care, it's supporting people in home care. It's supporting people in mental health hospitals. So, but what you can do is, if the uplift is 2 million, for example, for this year, what you could say to us is that the priority for the additional 2 million is X, Y, and Z.
Yeah. Okay.
Yeah. So that's
no. I get that. That makes sense. Okay. Thank you. Thanks for that. Thank you.
Okay, do we have any more questions? Oh, lovely. Right, we'll move on to the capital programme. The Director of Adults and Communities and the Cabinet Lead Member be invited to introduce the capital programme. Then invite questions and comments on the capital programme proposals as follows. Okay, this is covered in pages 30 to 31 and Appendix D, which is on page 39, paragraphs 101 to 103. Thank you.
Thank you. So we don't have a very large capital programme in adults and communities. So the total programme totals 25.8 million, of which 22.1 million is the Disabled Facilities Grant, which is essentially just passported to district councils. The balance of 3.7 million is discretionary funding, which has been in place to deliver the social care investment programme, which is effectively looking at developing accommodation-based support. So it's quite a small capital programme. We do have plans in place with 3.7 million, which is based around extra care, the additional extra care provision that we would like to develop, and some additional supported living for people with disabilities. In addition to that, in terms of future developments, there may well be a requirement for additional capital for the Archives, Collections and Learning Hub, or to address the outcome of the National Archives report into the Record Office. But as yet, that's not on the capital programme. Thank you.
Okay, lovely, thank you. So do we have any questions from members?
If I may, Chair, just on that last item then, the records collection hub. Obviously, this is an item that's been looked at previously and been recommended to Cabinet previously to make a decision on. So I'm just wondering if the Deputy Leader or anyone from the administration can make any comments about what their plans are for this hub, archives hub, because it's something that needs to be sorted out one way or the other. Is there any thinking about it at all?
Yeah, I mean, we had to act quickly because the accreditation was coming up, and we needed the extra space. So a medium-term strategy, I suppose, as John previously mentioned, is to use external storage facilities to get us by. Long term is a little bit more difficult at the moment because of the LGR. Obviously, it's a joint effort with Leicester and Rutland as well, and to discuss a large investment for a new storage facility without knowing the future from the LGR. You know, it's not something we can really come to any conclusion to at the moment.
Okay, so would that be fair to say that you've parked it off then until LGR is resolved?
I don't think it's fair to say that. Was not myself. John would be able to give you more information, but we're still in conversations with Leicester and Rutland. It's still a topic of conversation. It's definitely something that needs to be resolved, but a final conclusion is a little way off, I think it's fair to say.
Okay, thank you.
If we've got no more questions, members' comments will be forwarded to the Scrutiny Commission and thereafter the Cabinet for consideration. Is that agreed? Right. We now move on to item 9 and the recommissioning of Dementia Support Service as set out in pages 42 to 48 of the agenda. The Director, Inderjit Lahal, Assistant Director, Strategic Commissioning, will present this item.
Okay, thank you, Chair. And I'm hoping this this is a sprint, not a marathon, to be honest. The report details the commissioning proposals for the Dementia Support Service. The current contract ends in September 2026, and a new service will be commissioned in October, or for October 26. The current arrangements across Leicestershire and Leicester City, and is delivered by Age UK currently. The service supports LLR dementia strategy, which we launched in 2024 and runs until 2028. The annual value of the contract to the County Council is £265,000 a year. The ICB contribute £83,000 and the City contribute around £160,000. The City have proposed an additional £79,000 investment into the service model, which will target some hard to reach and BME communities. The current support service supports around 2,500 people per year. That's people with dementia and their families, and offers a range of support, including information and advice, support planning, access to groups, post-diagnosis support, practical support and solutions, and access to GP and health services. And that's amongst other things that's detailed in paragraph 10 of the report. Paragraph 12 details some of the challenges within the current service model. And these will be addressed in the new service, and in turn will also support our CQC improvement plan for the Directorate. Paragraphs 14 to 18 details the engagement activity undertaken with people who use services, their carers, and a range of providers through our market engagement events. Some of the key areas coming out of the engagement are around support with people accessing health services, again reaching the hard to reach communities and rural areas, and supporting people at different points across their dementia journey, and how councils and NHS services can work together to support people. Recent discussions with the ICB have confirmed that the ICB funding will be available and part of the new contract. The commissioning model across the county and city is being finalised to ensure that both areas receive best value from the contract, which was also aiming to deliver the requirements across both areas from a single arrangement. Paragraph 24 details the core measurements that the service will aim to deliver for the county, which focuses on access and reach, quality and experience, inclusion and impact and prevention. The timetable for the tender process is outlined in paragraph 28, with the tender due to be released in April 2026 and new contracts in October 26. In terms of the procurement process, the amount is set and the providers will be asked to outline how they'll deliver to the specification, added value they'll bring to the service through the organisation and delivery model, expecting providers to show how they can innovate, deliver seamless services and a strong model to ensure support for people with dementia and their carers is of a high standard. Providers will be asked to show how they can widen the reach to a range of communities through different methods and use community assets to support people across the county. Scrutiny Committee is asked to provide comments on the report, in particular the core measurements, and I'd probably be more interested to hear committee's views on any other areas for consideration, how we measure success and impact of the service. Thank you, and happy to take any questions or comments. I've got Kate Revel here, who's a head of service in my area as well. Thank you, Chair.
Was frozen, but they're still recording your voice, so that's fine.
Okay, thank you very much, Indy, for that. Before I take questions from or comments from members, Mr. Abbott, is there anything you would wish to add to this item?
Not at present.
Okay, Mrs. Page, if you'd like to go ahead.
Yes, thank you. Thank you for the report. And I've got a couple of questions. I'm not clear. So the current contract is with HUK, and unless it is extremely sensitive, there is no a reference what the next steps are, to whom it may go, if you can elaborate on that. Now then it goes on about the background of how many people are living with dementias, and again, have we got any indication of how many people are self-funders and having volunteer carers? Because all around me, I can name you 5 people who are having self-funding, having people living in, buying in service from, so then that brings me on to my next question. In a contract that is commissioning dementia support, what support are we giving to the people who are supporting loved ones with dementia? Because some friends of mine, they're really, really struggling, and, I'm always shouting at them because they can't get a head around, understanding what dementia means. Then, engagement. Now, we have in Lutterworth a fantastic facility called Our House, and I don't know if you heard about it. It is started, it was funded by Magna Park in Harbour District Council to the tune of $250,000, and it has an innovative dementia care which was run by a lady called Jackie Parks from the Northampton University, and it works on the basis that people do puzzles, sing and whatever, and apparently, so do we have an engagement with those volunteer people as well, because they do some tremendous work. I think we also have another one in Lutterworth in the Methodist Church, but Our House is really innovative in the delivery they're providing and oversubscribed. Last question is page 44. We concluded a separate service for each area would be more beneficial for both areas. Are we talking about going away from the city, or just talk me around that, please? And with that, thank you.
Thank you. I think we'll divvy these up between myself and Kate. So the first one So we haven't gone out to tender yet, so we won't know who our successful provider is up until I thought about June, July. The tenders are going out in April, so you text about 2 months, and then we'll evaluate and see who we get. It may be Age UK again if they bid and they're successful. It may be another provider, maybe a group of providers. We're not too sure about that, but we'll let you know as and when that happens. In terms of the separate service question, I'll just div in between the separate service one, the last question you asked. So we're still going out jointly with the city, but there will be kind of essentially like a core offer across the area, and then some more bespoke county type services and city type services. So it is still a joint piece of work across the area.
May I just interject? So in previous history, we've always, when we had a joint contract with the city and Leicestershire, you have residents saying, well, do we get our fair share? So do we, in the contract, build in a geographical, that everybody gets their fair share? Also, do we monitor and evaluate the outcomes for the individuals and the areas? Is that built in? Thank you.
So you've kind of answered the question in the last bit. So we have a monitoring process that is attached to the contract. So we look at activity, we look at outcomes, look at the geographical spread and how the service is hitting specific areas. If we need the service to focus on some of the more hard to reach and some of the areas that we want them to focus on, we'll push that as part of the contract. Kate, can I give to you?
My other question was, what do we do for the people who care for, their loved ones? And how about taking in to the engagement, besides service users, people like Our House, and looking what they deliver and whether that can be implemented?
Yes, thanks. So as regards to people who care for people with dementia, they will get some benefit from this service and currently do get some benefit, but may also be considered to be informal, what we call informal carers in their own right. So in other words, they're not paid for carers, and obviously we're mindful that family carers are absolutely imperative for supporting people with dementia, and so this contract itself plus other carers offer that the council have would be available to those people, and they would go through an assessment to determine what they needed. You mentioned one specific service in Lutterworth, Our House. I can't comment specifically on whether there's been engagement with that service, but I do know that, so as Indy said, this is a joint arrangement with the City Council. There has been extensive engagement with groups and with potential providers as well of the service for what we call a commissioning review of the service, which is something that we would do to determine how well it's working prior to going into commissioning and then the tendering, which Indy talked about there. So I can't comment exactly on the Lutterworth service, but there has been engagement with groups. And then I think the final element that hasn't been answered is around whether the county gets its fair share. And Indy talked about the contract monitoring. We do look at outcomes from the service, and we also can confirm that we do get our fair share. We do look at usage across the patch. Mr. King.
Yeah, thanks, Chair. Thanks for this. Sorry, could you did mention how much the city were putting in, or didn't you? How much are they proposing to put in?
I did. So the city's current contract allocation is £160,000, and they're looking to put an extra £79,000 in addition to that.
Okay, so that make
about £500,000 or 580.
Yeah, so about nearly 600,000. So a quick question then, are these amounts index linked with inflation, so that they go up over time, or do they stay flat for the duration of the contract?
The contract value's been constant for the last few years, but for the last 3 or 4 years, we have agreed a very modest uplift to that, which has then been removed at the end of each year. So in other words, it's a time limited 12-month uplift to reflect some of those costs, but the base isn't going up year on year.
Okay, so I think so it doesn't exist now, but I was vice chair of the Carer Centre for Leicester, Leicestershire and Rutlands before it was closed down. Not at that point. I just stood down as a trustee some years ago. But what I make the point is, organisations that have these contracts from local authorities, it's incredibly difficult if it's a flat contract and there's no increase, because guess what? They also have increases in national living wage. They have increases in utility costs. Whatever the things are that we're experiencing, they also have. To expect them to run a contract without any increase in provision is incredibly difficult, nigh on impossible, I'd say. So that brings me to actually say, I mean, it says broadly that there's 2,500 people use this service across Leicester and Leicestershire, although the contract's across Leicester, Leicestershire, Rutland. Is that, no, just Leicester and Leicestershire, right? Okay, but it doesn't tell us how many of those people are just in Leicestershire, which is what we're responsible for. You also say in paragraph 13 that a formal review was undertaken, but I haven't got any information about that as to what the service gaps and areas to improve and what needed to be done. My concern, based on personal experience of services like this, is it tends to be city centric. It's heavily branded with Age UK, so it's very difficult for service users to know. Not every person with dementia or Alzheimer's is over 70. A lot more people younger onset. So do they automatically think, I know, I'll contact Age UK to see if they, I mean, it's just a branding thing. And I think that's really important though. I'm not saying, obviously, I'm not having a go at them. I'm just saying it's a perception. Do I think it's a condition of old age? Because, like it or not, Age UK is associated with older residents, older citizens, and that's a fact. Their centre is in the city, so again, that to me they are city centric, and that's just my experience of these things. What do I think they should be doing? Well, I don't look after anyone with dementia or anything like that, but I do think carers support is really important. We know county councils reviewing carer support. You've got to do that because you've been told you've got to do that, and you've got to do that because of the inadequacy of the carer support that currently is provided. And equally, we know, so that's something else alongside this. So that then, just makes me think, is there some bigger piece here? But anyway, that's where we are. I just think that it's just, are the needs of the county and the city compatible really with this type of service as well? I mean, it's I don't know. I mean, just for me, a lot of what I see is, and I'm not knocking it, because the people who are involved, they value what they get. But again, I think it's also aimed at probably carers who are female mainly, rather than male carers. I know that's changed in the last few years, but a lot of the provision is aimed, is pitched at, you're a female carer, why don't you come and do this activity? It's not necessarily aimed at men who are caring for their wives, their partners, or obviously it could be other men. So I think there's an issue there about, are some of the activities that, because a lot of it is group activity based, are some of those activities appropriate for people? And I just, I just wonder about some of that, because if I was in that situation, they wouldn't be attractive to me to go along. They wouldn't entice me to go along to a group. And again, I'm not having to go at those things, because the people who go to them are, they enjoy them thoroughly, and it is important for them. But are they things, you're talking about hard to reach groups? Well, male carers are hard to reach. Okay. And that's the thing. And I think this whatever the contract is, it needs to address that. And obviously, I know there's things with different ethnic groups as well, where caring isn't really recognised because there's even a word for it. So I think that's some of the issues. I think the other thing as well is financial advice and information. A lot of people with caring responsibilities, they focus on the caring side of it, but we just talked earlier a lot in this meeting about money. A lot of this is also to do with financial effects on a family or caring situation. Someone might have to stop work, they might have to give up work, or reduce hours. It might have an impact on someone's ability to maintain the house where they live, all sorts of things. So I think, in my experience, although it's talked about, there's not that much active support available for people. It's more or less, well, there's some information on a website, go and look at it, and go, there isn't anyone who you can actually easily access. Again, there are support services, but they're in the city. You've got to come in to access that, and then that comes into the logistics. And if you're out in the rural part of Leicestershire, that's a long way, and it's not necessarily easy for someone to come in and do that. So I think it is complicated, but I think there's some other things that I've certainly experienced, and I think they pertain across a lot of different looked after conditions, not just dementia. Thank you, Chair. That's what I wanted to say. Thank you.
Just before Kate jumps up, they're all absolutely valid points. Some of the specific work out in the more hard to reach rural areas is part of what we'd expect the provider to do. So they may be based in a certain area, but we've got our library services out in the communities. We've got other bases that community organisations do. That one in Lutterworth you spoke around as well. So part of the contract might be actually will ask, the provider may want to use and support those organisations to deliver part of the service as well. So there's kind of ways around kind of dealing with and getting into different parts of the communities. Absolutely. Some other points are absolutely valid as well. So the male carer one, absolutely a valid point. Paragraph 18 in the report does talk around how we need to kind of define, and the last bullet just talks around how we need to define support for carers of people with dementia as part of the arrangement, and how it links to our carers offer. So we've got as you know, we've got our current carers review. The two services, they are separate, but they do absolutely link. So how do we kind of create the efficiencies and joint working between the two contracts? And that's something we'd absolutely look at. But yeah, all valid points. Absolutely, we'll definitely take those on board. I'll hand over to Kate.
Thanks. Just to add to some of what Indy said, service gaps from the review are highlighted in paragraph 15, and the additional information that you've given is really useful. I think, as Indy said, particularly around male carers, that is really interesting. And I think just moving on to the city-centric perceptions. What I would say is we are moving now to, although we are joint commissioning still with the city for economies of scale, we are also going to be moving to a two-lot approach, which means that we're able to better tailor what we want from for the county from the tender, without having one generic model for the whole area, and that will help us better address issues like rurality, which you identified there. So although it's still a joint commissioned approach with the city, we will still have lots specific to city needs and to county needs, and hopefully that will start to address some of the perceptions around or reality around the city-centric nature of some elements of the service at present. I think you mentioned financial advice and information. Again, really useful feedback. So we'll ensure that is something that's brought up within the new arrangements. There should certainly be signposting available to that at the moment, but I do hear what you're saying about actually referring people to a website may not be sufficient. So I know it's probably quite easy to say that, we'll address all these things within the new contract and it'll address all of those issues. These are all things that we're obviously seriously considering as part of the tender arrangement. Just the final bit from me is around the Age UK branding. I do totally understand what you're saying about early onset dementia and the Age UK branding, obviously not necessarily speaking to that. That's just a function of the provider that we have in place for it at the moment. I do understand what you the point you're making there. So obviously it may not be Age UK who secures the tender going forward, but if there is a branding point to make, we will try to address that.
And Mrs. Barber?
Thanks for that. The other point, really, the other thing I wanted to make, which I did make, was about the indexation of the contract, the value of the contract. If it's just a flat contract, it's really, really, I mean, the way this is set out at the moment, this assumes that to me, this presumes, it makes a presumption, or it tends to suggest that a large organization will take up this contract. It wouldn't make it necessarily terribly viable for a smaller organization to take this up. And if what you've just said about having 2 lots, that again would tend to, I just wonder, it just raises questions about the financial viability of this type of contract. So I think they are real concerns for the VCS sector. If you're looking for someone to tender for this type of contract, it makes it incredibly difficult if it's going to be fixed value for the duration, and if it's going to be then broken up into 2 lots. I understand why your rationale for that, but turn it the other way. If you're on the other side, it makes it even more difficult. And the money advice thing, yeah, what I was meaning by that is people when they're looking after people, it's incredibly difficult. It's very time demanding. It's incredibly difficult. But actually what they need is they can get someone to see and actually meet up with and go through things. And that service is, there is one, but it's not, again, it's not available in the county. You can't get very easily to see someone. You've got to ring someone up, you've got to go online, and that's not necessarily someone's priority when they're looking after their loved one, is it? So I think, if we've got an ability to improve that, given that financing has become much more complicated for people, I think it's a really important area. And then hopefully, Director talked about prevention, and this is one of the areas where you can prevent people requiring care, because they make the right financial decisions through informed choice, informed information, rather than making a mistake and then finding they haven't got the money to fund care when they need it. So I think it's really important, and this is an opportunity to improve this for people who historically have found it really difficult to make the right decisions. Thank you.
Thank you, Mr. King. I think your points have all been noted. Thank you very much. Mrs. Barber.
Thanks, Chair. Fiona Barber from Healthwatch Leicester and Leicestershire. So in our daily listening to various communities, we get a reasonable amount of feedback surrounding people's journey through the diagnosis of having dementia. Some of the practical issues that they feed back to us are, firstly, the timeliness of that particular journey, which isn't something this contract is going to address, but it is an issue. And then there are all sorts of practical issues as people are going through the journey, arriving from what sort of care they might need to things like driving. Can I still drive my car? What sort of support can I get? We've touched very briefly on the information and advice, but particularly things at early diagnosis, people tell us that things like power of attorney, will advice is up there in their minds, because people start off with the worst case scenario and then generally work backwards. There's also people are not sure where the link is within the general practice and the GP services. So and I don't see any linkage initially jumping out from the page. So I think Healthwatch would like to see some kind of tie up and link through the health side, because that is going to be important on people's journey. And in terms of people who are there pre-diagnosis on their journey to there, because the timelines are as they are at the moment, it would be useful to have a really clearly defined offer at that pre-diagnosis stage. Once people have been diagnosed, that's a different kettle of fish. People have more clarity in some respects and they can take those issues forward. But the feedback from People to Health Watch is give us the clarity, give us the support, give us some guidance. In the paper, paragraph 16 does mention holding a further focus group with members who have a lived experience of dementia and their carers, which is different to the engagement panel used by the County Council. And I'd like to understand where you are with that and how that feedback will actually come into the paper and the contract, given the timescales you've already mentioned. So if you could give us some understanding of how you're going to do that and when, so that can feed in, that would be really great. I think Health Watch would also want to highlight in the provider feedback you've got, which I think is 18, paragraph 18, one of the issues we brought up was a touch on the working with smaller community-based organisations. Now, that has always been really useful and it helps support access to different services right across the community, which is, I think, some of the point that was being made earlier. There's also the issue, of course, about joining up the city and the county because people don't recognise the boundaries easily. So if somebody's working in the city who lives in the county and has a relative that they're looking after, they might bring them into the city to access services or to access an event or something. So there must be some understanding of how people can do that. They can ride backwards and forwards. So if somebody lives in the city, been diagnosed, but has family in the county and they come to stay with them, how's that going to work? So how's that crossover applicable? Because that's a regular occurrence, moving backwards and forwards. Just on the voluntary sector stuff, one of the key issues, of course, is money. How do you pay for that? Is there likely to be some kind of facility within the contract that allows the contract holder to pay smaller community groups, and I mean really small community groups, to host events or sessions or something or other that would meet the needs of those people or carers in their particular communities? So that's an issue too. And the tender timelines seem exceedingly tight to start a service off in October, but not to announce it until July. You need 90 days, don't you, in terms of the employment side? So I'm just wondering how that's going to work and what sort of provision have you got just to push that back a bit? Is there a provision to keep this current contract running for a month or two while you've got the employment timescales absolutely right? Otherwise, there will be major significant issues. And I think really that's all from a Health Watch perspective. Those practical issues, I think, rather than anything else. Thanks.
Yeah, thank you. Some really useful points which I've made a note of. I'll start with your last point first. The timescales are tight, but they do allow for TUPE if that was to be required. So the transfer of staff if that was a requirement. So within my team, we have procurement officers who are able to advise around all of those timescales. It is tight, but it is doable as we sit here today. Just taking your point about whether the provider would have an opportunity to give grant or make payments to community groups, that is something that we're considering, and whether that would need to be a sort of formal subcontracted type arrangement with the lead provider sitting above all of that. But we're considering that, but also trying to make it as light touch as possible, balancing our own procurement rules with the need for something really quite light touch within the sector. You mentioned cross-border. We're hoping that even though it is a two-lot model, there will be elements where the two lots have sufficient in common to allow for that kind of cross-border approach. But if it goes to two different providers, we'll obviously need to ensure that we understand how they work in the two areas for one person if that's necessary, because as you say, people don't neatly stay within their own geography, do they? And we need to be able to respond to that and give them a sufficient service. You talked about engagement panel session. There has already been a session on this with the council's own engagement panel, and the proposal is to run another one with the Leicestershire engagement panel. So that would be members of that panel, and the city would presumably arrange something with their equivalent structure.
Come in on that specific point. It mentions here in the paper holding a further focus group with members who have lived experience of dementia in their carers, which is not the same as the engagement panel, who are a broad range of individuals. So, and I think given the nature of the proposed tender, it is essential that we have a specific specialist focus group. Thanks.
That's a fair point. So in the engagement plan, there are some people who are carers of people with dementia. We do have a number of other carers networks that we do link with, like our recent carers engagement, which will come to scrutiny in March. You know, we did quite a lot of engagement with carers, really good voice across the county, a couple of hundred carers engaged in that. So we've got our networks, but I agree that the next piece of engagement needs to be specific. So I think that's what you're saying, is that you can't go quite broad and say engagement panel engage. It will be more specific. Age UK do have their own engagement, and they've got their own members who we do speak to as well. So that's part of that, is getting the right people in the right place.
Thank you. I know that some of the points you made were points rather than questions. So if you think there's anything that I haven't addressed, then do please ask.
Okay, lovely. So the report is an update for us to note. Is that agreed? Lovely. Next, we move on to item 10, which is the Care Quality Commission Assessment 2025 Improvement Plan Delivery Update at pages 49 to 58 in the agenda. This item is for information only and is taken as read. Therefore, we move on to item 11, which is the date of the next meeting. Members are asked to note that the date of the next meeting is on the 2nd of March 2026. I would just like to add that my birthday is the day before. And item 12, any other items which the chairman has decided to take as urgent. As stated at the start of the meeting, I have no urgent items.